Okay, welcome. Thanks for tuning in for this is a webinar on rehabilitation of rotator cuff injuries. And my name is Robert McCabe. I want to thank you for tuning in for this webinar. As the title indicates, we're going to talk about conservative management of rotator cuff injuries. I am a physical therapist with OrthoSC at the Market Commons location. So today we're going to talk about a little bit of background on the prevalence of rotator cuff disorders. And as far as risk factors, we're going to talk about who's at risk for developing rotator cuff tears. We'll go through the rotator cuff anatomy and then also talk about specific rotator cuff injuries and conditions. And then we will go a little bit into how a rotator cuff is diagnosed, how a rotator cuff tear is diagnosed. We'll talk about MRI, other tests that can be used. And then for this talk, probably the most interesting, at least for me, is, given my background, is the rehabilitation and the approach for rehab and rotator cuff injuries, and what our approach is in terms of conservative management. So we'll go through all that as well. And then if you have any questions, please feel free to ask them at any time. And I can answer the questions as we go through the talk here today. So how prevalent are rotator cuff tears? They're very common, especially in the middle to older age population. Very common in the general population over 50, actually. And then in those individuals that are very active, tennis players, golfers, those that have, weight trained over the years, and now they're entering into their fifth decade of life or sixth decade, these injuries are very common. So the fitness boom of the 80s, if you think about it now, those individuals are entering their 60s, 70s, and so many years of weight training and exercise is starting to catch up. And we all know that there's benefits of exercise, but there's also can be some overloading of the tendons. So here's a couple of statistics. Rotator cuff tears account for 2 million visits a year. If you're over 60 years old, there's a likelihood you have a rotator cuff tear, even if you don't have any pain. So they've done this, they've researched this well out, and they've found that MRIs, they've done studies where they've taken MRIs of asymptomatic people, in other words, people without pain, and more than half of those patients over the age of 60 were found to have a rotator cuff tear. And many of those patients that have a tear don't even know it. So it's very possible to be walking around, living your life with a rotator cuff tear. If you're between the ages of 50 and 60, there's almost a 50% chance that you have a rotator cuff tear. So it starts relatively early. It is also seen in the younger population, but this is usually due to strictly overuse. Whereas in the older population, it's a degeneration type of condition that can be combined with overuse. But in the younger population, more likely to develop this with, highly stressful exercises or activities such as, for example, a baseball pitcher overhead athlete, competitive swimmer, and those individual CrossFit athletes and the like. In fact, I think for CrossFitters out there, for the younger population, rotator cuff injuries are, I believe, either the first or the second most common injury. Lower back pain and shoulder pain are the two most common causes. So these are some additional risk factors besides being older. There's also those individuals, again, that are involved in occupations perhaps where they overuse their arms. So some specific ones that I can think of off the top of my head are painters, construction workers, dental hygienists, X-ray technicians, because of the repetitive lifting and moving of the arm. And then also you see this in, again, professional athletes. On the opposite end of the spectrum, you see this in highly deconditioned patients who don't exercise. So there's probably a happy medium in terms of applying stress to the tendon. If we overstress it, it will break down. But if you don't stress it enough, perhaps it will start to degenerate earlier. That's kind of a theory, but it makes sense. Nicotine is a really strong risk factor. So if you're a smoker, especially a long-term smoker, nicotine has really adverse effects on the tendon. So this is just a picture of the tendon, a rotator cuff tendon, and the nicotine has been shown to decrease the blood supply and the healing of tendons. So if you already have a tendon injury, then nicotine can actually slow the healing process down. So for example, if you have a rotator cuff tear, smoking theoretically would delay the healing. We're not going to talk about surgery, but especially for patients that have had rotator cuff surgery, it's highly recommended that they quit smoking if they can during the recovery period, at least the early recovery period, and even hopefully long-term. Steroids, anabolic steroids have been shown to be correlated with tendon injuries. There's a couple of studies that show high cholesterol may be linked to tendon injuries or degenerative tendon problems. That's not, I wouldn't say a lot of evidence behind that. A couple of studies have shown that. There's definitely research that shows that if your parents have a rotator cuff degenerative injury or disorder, then there's a good chance that you may develop one in life. So this does tend to run in families, just like a lot of conditions such as arthritis, and it's no different with rotator cuff or tendon injuries in general. So sorry for the repeat. This is really just kind of the same slide as on the previous page, but again, this is just showing a rotator cuff tear that you can see, not to dive too deep into the anatomy, but this would be like what it would be considered normal tendon. This is kind of this frayed tendon that you might see. And the analogy is much like a frayed rope. Tendons should be very well organized. And then with these degenerative tears, where there's not an injury, but more of a aging overuse, you see sort of the fraying of the tendon. And you can see the beginning of a tear here, right in this area. So again, not to go deep in the anatomy, but I do want to just review the basics on the rotator cuff in terms of anatomy. So the rotator cuff is really 4 muscles, 4 tendons, technically, that come into your shoulder. And so we're showing here one tendon. Not that you're going to remember the names, but this is the main tendon that's often injured, the supraspinatus tendon. Second tendon is here. Third one right here. These are at the front of your shoulder or the top of your shoulder. And then there's also the one that comes in from this angle. But basically, there's 4 tendons that kind of converge on the shoulder. And they're, depending on the size of the tear, one or all of these tendons, very unusual to have all 4 involved, but 1, 2, or 3 of these tendons can be often torn. So also there's a bursa right around that area. So if we go back to the previous picture, right above these tendons in this area is a bursa, and that cushions the between the bone here, over on top here is the bone of your clavicle, which is your really your I'll point it out on myself. So it's the clavicle is right up here, and that would be this bone. Between that and the rotator cuff is a bursa. And that can get inflamed when there's problems with these tendons, given that they're right next to each other. So tendon injury, degeneration, tear can lead to or is connected to a bursitis often. And that a bursitis is an inflammation of that fluid-filled sac. So here is another picture of a swollen bursa or a bursitis. And that is, again, right next in between the bone, which is here, and underneath the rotator cuff tendons. So there's not a lot of room to work with. When you go to raise your arm, so this is the arm, when you raise it, you don't have a lot of space in here to work with. So you can get a lot of compression on the tendons and the rotator cuff bursa. One of the important things to keep in mind, though, is that these muscles in your upper back around your shoulder blade are very important for providing a stable base for the shoulder. So we're going to talk about rehabilitation and what we do in rehab, and certainly we work on rotator cuff strengthening, but also posture and some of these exercises specifically to target around the shoulder blade. Because if you think of the shoulder blade as almost like the core of your shoulder, this is like the base of the shoulder that rotator cuff muscles can kind of feed off of. So you need to have good muscular control and stability of these muscles back here. So how is a rotator cuff diagnosed? Well, typically the physician, orthopedic surgeon, primary care, sports medicine physician will diagnose these right in the clinic. Based on the clinical exam, they'll measure your strength, your range of motion, and they'll determine your diagnosis. And surprisingly, that is quite accurate, not 100%, but pretty good accuracy as far as coming up with a diagnosis of a rotator cuff injury, impingement, or rotator cuff tear. Certainly imaging is better, but this is often not cost effective, and it wouldn't necessarily change your treatment anyways if they did an MRI early on. Typically the physician will do an x-ray, but the MRI is often held off if you need it. In other words, if conservative treatment is not successful, i.e. physical therapy, then they start thinking about an MRI down the road, perhaps after 4 to 6 weeks of unsuccessful therapy in some cases. But again, even if they were to do an MRI early on and they found a tear, it would not be an automatic indication for surgery, because we know that a lot of patients, a lot of people are walking around with rotator cuff tears. So the MRI, if necessary, later on can confirm if there is a tear. And I think the value of the MRI is that it can give you a lot of details. In other words, how big the tear is and how deep the tear is. So orthopedic surgeons classify these tears according to how big they are. So if you're looking down on a tendon, in this case, this is a supraspinatus, but the most commonly of the 4 tendons that's torn, that's a pretty big tear. That's a surface area. All right. Now these are going to obviously be more challenging to rehabilitate than a small tear. But also how deep the tear is also important. So this is looking at your shoulder again. This is the tendon, and you can see that the tear goes all the way through, top to bottom through the tendon. So the deeper the tear, the bigger the tear, the little more challenging they are to rehabilitate. Now, that's not to say they can't be rehabilitated. It's just that the larger they are, the more challenging it can be. Certainly, there are cases of patients that have these very large tears, and physical therapy can still be successful. But generally speaking, the The smaller they are, the better the prognosis. So once it's diagnosed, and I should have mentioned ultrasound can also be used to diagnose rotator cuff tears with a very high accuracy as well. But once it's diagnosed, then there are options out there for the patient, and the orthopedic surgeon or physician will determine this, but often it's cortisone injection. Back up for a second. Usually it's physical therapy first, and then with or without a cortisone injection, depending on the surgeon's clinical exam. So, and then activity modification. Very important that you avoid what is causing the injury. So if it's an overuse injury, then we have to look at what is the overuse activity and try to minimize it. And this can be challenging in somebody who's working and they can't take off work. But for example, if you're playing tennis or pickleball and you develop this shoulder pain, then we recommend strongly to take a break from that for at least a period of 1 to 2 weeks while we start performing some physical therapy on this. Can't stress that enough, how important that is, because if you keep doing something that injures a tendon or the bursa, it's almost like pouring gasoline on the fire, so to speak. It never has a chance to calm down. So we definitely want to avoid what's causing it. Now, what do we do in physical therapy? Obviously, we cannot fix the tear. That brings up a good discussion. Do these tears actually heal? While it's been shown that these tears can kind of fill in with a little bit of scar tissue, not exactly the normal tendon that's being replaced with healthy tendon, but it can be filled in with kind of a soft tissue, a scar-like, collagen-like tissue, which serves to fill the gap. But again, a lot of this depends on the size of the tear. If it's a full thickness tear, then it's not going to fill in as much, obviously, but if at all. But we can't fix the tear, but some healing can occur naturally over time. But what we can do in physical therapy is we can improve the shoulder strength, rotator cuff strength, work on that scapula stability that we talked about, the upper back muscles, and also work on posture. Didn't bring this up, but forward shoulder posture, which many people adopt over after the age of 50, we often have these postural changes. We go into a forward shoulder or forward head posture. Well, that actually puts additional strain on the rotator cuff tendon. So we can definitely improve posture to help take stress off the tendon. Rotator cuff strengthening exercises, a lot of these depends on what stage you're in, how much pain you're in. We have to modify these based on your situation. We certainly don't want to cause a lot of pain. And so there's a whole hierarchy of exercises. So it's hard to say, give you 1 or 2 must-do exercises. It really does depend on the patient. We can do isometric exercises, which is pushing against the wall, or we can do more like TheraBand exercises and weights. It really does depend on the patient. There is some value with some hands-on stretching, some joint mobilizations, which can be done by your therapist. This is to create more space. That's kind of an oversimplification, but basically free up the space in the shoulder so there's more space so that the tendons are not going to get as irritated. So we can do that with some manual therapy techniques and stretching any tightness in the shoulder joint or the muscles, which further take away that space that the tendon has to slide around in underneath the bone. So some of these exercises are exercises, for example, such as rowing exercises with bands. But again, there's a lot of different exercises out there, and it really does depend on the patient. Really important to avoid stressful motions of the shoulder. And one that I can think of that comes to mind immediately is reaching back into, like, for example, the car seat and grabbing something off the seat, pulling it forward, reaching back to put your coat on. Well, we're in South Carolina, so we don't have coats, but in the north, we would have like put more your coats on more often. Reaching a long sleeve shirt. Um, if you're going to lift heavy weights, such as bench presses, overhead presses, these are all pretty high risk activities, and we have to modify how we do these. So in the 50-year-old group who's been exercising for several years, bench presses, push-ups, overhead presses, those kind of movements have to be modified and worked around a little bit for a while until until the tendon heals. So that's very important as far as that goes. Also, self-management also includes using ice if it's inflamed, and often heat can be used as well, but more often ice because these tend to be these tend to have some inflammation associated with it. So I prefer using ice on these type of injuries until proven otherwise. So if the ice does not help, in some cases, heat can be beneficial. And I think sometimes this is more beneficial for those patients that have that combination of arthritis and tendinitis or tendinosis, degenerative tendon problem with arthritis. And in some of those patients, heat actually feels better. But the problem with heat is if you put it on and you have a bursitis, you can make the pain worse. So we tend to advocate ice more often, and then try heat only if ice has no effect. And then these are some common questions that I often get asked in the clinic that I'd like to go through some of these. And then if you have any additional questions, certainly would like to go through those as well. So one question I get asked a lot is, how long does it take for physical therapy to help? Because patients often come in and they are under the impression that they need to try therapy for like 6 months. And that's not the case at all. Usually, based on my experience and also based on the research, there should be some noticeable improvements in 3 to 4 weeks. So it's not a real long time to know if physical therapy is going to be successful. And that's not to say at 4 weeks, you're not going to make any more improvements, but 4 weeks is enough time to determine if therapy is going to work. If somebody comes in and we're not seeing results in 4 weeks, it's very, in my experience, again, it's just based on research as well, it's very unlikely that they're going to suddenly make a substantial turn at 4 or 5 weeks. So the short answer is it doesn't take long to tell if therapy is going to help, which I think is a good thing in terms of planning. If surgery is warranted, then it's good to know that upfront. And this is another question that I can't tell you how many times I get asked. I don't want to start therapy. Shouldn't I get an MRI before I start physical therapy? So we know exactly what is going on. And that is really, in a perfect world, I guess we would have an MRI that would show us everything. But again, it would not really change your immediate treatment unless it showed you have, a massive rotator cuff tear. And on top of that, you came in and you could not even raise your arm. It could confirm that you have a real bad problem that therapy is not going to help. And in that theoretical case, it might help. But again, we're not, many patients come in with rotator cuff tears and they respond to therapy and we didn't fix the tear. So the MRI is going to show a tear and the tear is still going to be there after therapy, yet in many cases, patients get better with physical therapy, but we didn't change the tear. So So it really doesn't make a lot of sense to really get an MRI, because unless you're going to use it as a justification for surgery, but often, that's not practical to get an MRI. So no, don't worry about starting therapy if you haven't had an MRI. Another question I get asked related to that question is, um, just to go back to this one, is, well, I'm worried about doing therapy because I don't want to make this tear, if I have one, any worse. Well, the thing with therapy is that we don't really try to push aggressive exercises. And one good thing about your body is that it will, if you stress an injured tissue, generally it's going to cause pain. So we use pain as our guide for our exercises. If you're able to perform these exercises, and we start with the lower level ones, then and it's not causing pain or very little pain, then you can be assured that you're not overstressing the tendon. So your body is very good at sending you a signal whenever you're putting stress on an injured structure. Now, one important thing that we tell patients is that all the exercises should really be painless or cause minimal pain. And so we use that as our guide. Another common question, again, we already kind of answered this, is should I use ice or heat? Again, for me, I would say ice almost all the time, but every now and then you get a patient that comes in that responds better to heat. And again, I think they might have the arthritis component might be causing more of their pain as compared to the tendon problem that they might have. So this talk is not so much on arthritis of the shoulder, but you can have combination injuries like rotator cuff injury with arthritis. And in those patients, maybe heat does help a little bit more in some cases. I already answered this question. Sorry to jump ahead, but can physical therapy make the tear worse? And again, not if it's approached carefully. It should not make the tear worse. Now, there are cases, and I've had maybe one or two over the years, where a patient came in and they said the therapy made it a little bit worse afterwards, but 95% of the time it happens right on that session, during the session, while they're exercising. Like I said, I've only had maybe one time I can remember, twice, where somebody came in and said, it didn't hurt during, but it hurt after. So we always ask patients if it's hurting during the therapy. And those are some of the main questions. So I would like to just finish up with that by saying that that rotator cuff injury is a very common condition. One of the most common conditions we treat. Physical therapy has a relatively high success rate. And in those patients that don't respond to therapy, it is the way we like to look at it is it's strengthening exercises that would prepare you for if you were to have surgery. So you can't go wrong by strengthening the shoulder prior to surgery if you ultimately end up needing surgery, which is a very successful surgery also that should be mentioned if surgery is absolutely necessary. So I just want to mention that, again, my name is Robert McCabe, and we do have we do have appointments that we are accepting at Marketplace Commons, and you can speak with or leave a message with Lisa Sanders, or you can call the facility if you're in order to set up an appointment. And right now there are same-day appointments available.